Good afternoon. Welcome to the City Club of Cleveland. My name is Mike Anderson, and I serve as Vice President and Chief Medical Officer at University Hospital's Case Medical Center. I'm very pleased to introduce today's special speaker, Dr. Nicole Lurie, the Assistant Secretary for Preparedness and Response at Health and Human Services in Washington, D.C. As the Assistant Secretary for Preparedness and Response, also known as the ASPR, Dr. Lurie serves as the Secretary's principal advisor on matters related to bioterrorism and other public health emergencies. Her office is the lead agency for federal public health and medical preparedness and response, helping the nation prepare for, respond to, and recover from disasters. I've had the pleasure of working with Dr. Lurie over the past 3 years, specifically on the needs of children and disasters. I found that Dr. Lurie not only is a wonderful patient advocate, but also a visionary leader and a wonderful public servant. Prior to becoming ASPR, Dr. Lurie served as the Senior Natural Scientist and Paul O'Neill Alcoa Professor of Health Policy at the RAND Corporation. She has previously served in the federal government as the Principal Deputy Assistant Secretary in the Clinton administration, and in state government as the Medical Advisor to the Commissioner at the Minnesota Department of Health, and in academia as a professor in the University of Minnesota Schools of Medicine and Public Health. Dr. Lurie has a long history in the health services research field, primarily in the areas of access to quality of care, managed care, mental health care, prevention, public health infrastructure, and of course preparedness and response. In the academic world, Dr. Lurie attended college and medical school at the University of Pennsylvania and completed her residencies and masters in public health at UCLA. In addition to all of her responsibilities in HHS, Dr. Lurie also continues to practice clinical medicine in the healthcare safety net systems in Washington, D.C. We're very proud to welcome Dr. Lurie to the City Club of Cleveland, and I hope you extend her a warm welcome. Dr. Lurie.
Well, thanks so much, Mike, for that warm welcome. It's absolutely a pleasure to be here in this historic institution. We were talking before about what an important thing it is and what an important treasure it is for the community to have a place for civic dialogue and debate and discourse. And there's no time, I think, that's more important for that kind of an environment than now. What I thought I would do today is talk to you a little bit really about my experience in this job as the Assistant Secretary for Preparedness and Response from the perspective of what real events have taught us about public health preparedness and response, because I've had the honor, I think, and challenge of leading and serving in this role through a whole series of events now. Starting with the H1N1 pandemic, as that was slowing down, we had our first really large-scale international medical response to the Haiti earthquake. Dealt with two other things that may or may not have been recognizable to several of you as public health emergencies, or epidemics of fear, largely Deepwater Horizon, and then the Japan nuclear crisis. And then more recently, the more classical kinds of disasters that we faced, the Joplin Tornado and Hurricane Irene. So I thought I would talk to you about a number of common themes that have emerged through the experience of dealing with all of these events in the last 2.5 years. Let me start by saying that my office, known as you heard as ASPR, was really created as a lesson learned from Hurricane Katrina. At that point, I think it was recognized that there was not a single focal point for coordination and accountability for health and public health. And so this office was created. And my role is really as the Secretary's principal advisor on public health emergencies, including bioterrorism and other threats. We are guided by the National Health Security Strategy, which has two overarching goals. One is to build resilient communities, and the other is to strengthen health and emergency response systems, and we can talk more about those. I want to stress that the National Health Security Strategy is a national strategy, not a federal strategy, and as such really embraces a whole community approach, public-private partnerships, coordinated, integrated resources of investments, and is really built on a system of measurement and accountability and continuous improvement, if indeed we can't learn improve from each of these kind of events that will never really achieve the state of preparedness that we seek. I think most of you are familiar with the fact that after September 11th and the anthrax attacks, people woke up and realized that there had been at least a quarter century, if not more, of significant disinvestment in the public health infrastructure of our country. And woke up and said, whoa, we're in serious trouble here. What are we going to do about it? And started pouring a lot of money into the public health system, really to strengthen public health preparedness. I'm here to tell you that, by and large, I think that those investments are really paying off. And they're paying off in a lot of different ways. First of all, in what they have done for the public health infrastructure in this country. When I first got into this field, which was just after the September 11th attacks, most health departments in the country didn't have a computer. They weren't connected to the internet. We did tests of the healthcare system and found that many couldn't answer the phone 24/7 to receive and respond to urgent case reports. And things were really, I think, in much worse shape than many people realize. And so systematically, we've built back surveillance capacity, epidemiologic capacity. Terry Allen and I were just talking about the fact that many counties in Ohio had no epidemiologists before we started worrying about preparedness. Laboratory capacity, and the capacity for countermeasure distribution, and frankly, the capacity to communicate with the public and with one another about how to protect themselves in a public health emergency. Remember, wash your hands, cover your cough. So, we couldn't have gotten that message out, 10 years ago, let alone if you were in a life-threatening emergency. At the same time, we started to build back capacity in hospital and healthcare system capacity, because we realized that saving lives was also going to involve the medical care system, medical surge capacity, our ability to move patients around and evacuate them in disasters. Remember Katrina and Hurricanes Rita and Ike? We couldn't do that. And really to strengthen the national disaster medical system. And then I think the third part of this three-legged stool is the emergency management infrastructure. Now in this state, I know that EMS, for example, is part of emergency management. And so I think historically, in many states like that, not here, emergency management and public health don't talk very much together. Emergency management and the healthcare system do this handoff at the door of the emergency department, but beyond that, don't collaborate as fully as they need to. And so a bunch of investment in the emergency management infrastructure, both in that pre-hospital care domain and in incident command. So in the series of events that I've been involved in over the past 2.5 years, we have really needed to call on so many of these core capacities. And I'll start with H1N1 in a couple of different ways. And first of all, the fact that we had built back a surveillance system in this country is notable. Many of you will remember that those first cases of H1N1 were detected actually by an experimental point-of-care diagnostic test that was being pilot tested in California. That's because we had made a pretty big investment in doing better with surveillance and doing better with diagnosis. And throughout this whole pandemic, used the surveillance capacity that we had built back, whether it was syndromic surveillance, influenza-like illness surveillance, the connect between the health department and surveillance that went on in emergency rooms to be able to function. Laboratories, public health laboratories, clinical laboratories, hospital laboratories, really all over the country surged to be able to detect and diagnose H1N1. As you know, the CDC made reagents in record time and made them available to all states, and in fact many countries around the world. And when I travel internationally, one of the things that I hear from so many countries was a thank you for getting that diagnostic capacity out in so many countries so quickly so that they could do their own early detection system. My office is also responsible for countermeasure development, whether it's for vaccines against bioterror like smallpox or anthrax, or vaccines for pandemic, so H1N1 vaccine. And although we made vaccine in record time, it was not fast enough to deal with, by and large, the speed of a pandemic. We were about 2.5 or 3 years into a 5-year plan to build a pandemic vaccine capacity for the country. We are a lot further along now. And just last month, I actually went to the pandemic readiness celebration of the cell-based manufacturing plant that we have in partnership with Novartis in Holly Springs, North Carolina. So we've come a really long way and have come way forward also in our ability to manufacture vaccine quickly. We now have a national goal of being able to manufacture vaccine quickly against a threat that we have never seen before, sort of getting away from this one bug, one drug idea. We also had practiced a lot before H1N1. How would we distribute countermeasures to the population if we ever needed to? Whether it was antibiotics in the case of an anthrax attack, and many of you have been involved in those drills and exercises, or vaccine in many places around the country, including many in Ohio, practiced during seasonal flu. How they were going to do that mass distribution and mass vaccination, and boy, did it come in handy during H1N1. Built medical surge capacity and the ability to understand what was going on in hospitals and what hospital capacity was. And we're at the point that our health departments and most county health departments had a public information officer. The communication and the communication capability we had at a national level, at a state level, and a local level, I think was really one of the things that made a huge difference in H1N1. I also want to step back for a moment in that and talk a little bit about a whole of government response. Had you asked me when I came into this job, could all the parts of federal government get in one room and coordinate about what to do? Could all the parts of HHS do this? Could governments across the country do this? I would have been really very cynical. I will tell you it was an amazing experience to be able to go to a weekly meeting at the White House with all of the other departments and sit in a room in a coordinated way and share information, to have state and local health departments there with us in our operations centers, in other places, so that information was seamless horizontally and vertically. Yeah, it had its hiccups every now and then, but huge effort and huge payoff, I think, on that coordinated response system and on the coordinated communication systems and messaging. So just as the pandemic was starting to tail off, the earth shook really, really badly in Haiti, and I think you all know, and I know some of you actually went as volunteers and responders to help with the Haiti earthquake response. The National Disaster Medical System had once before deployed internationally in the Bama-Ran earthquake, and it sent, I think, a team. In this case, we had a very large scale, really our very first large-scale deployment. At the time it happened, there was no whole government plan for how we would respond to a disaster in another country. And that, I think, had its challenges. But again, fresh from the H1N1 experience, we were all able to sit together and coordinate and work out things pretty quickly. I think that experience was a reminder, first of all, of the multifaceted nature of resilience. And remember, I talked about building resilient communities. A lot of that from the health side is about resilient people, people who are healthy to start with, people who can run, people who are physically fit, people who are mentally and emotionally healthy to start with, and helping them to recover after an event. But there's also a physical aspect of resilience, and we shouldn't forget it. Were we to have an earthquake like that here in Cleveland or in San Francisco, some buildings would fall down, but not every building would pancake, right? Because we have earthquake standards, because we build to code. We don't build in floodplains, or we try not to, let's put it that way. We do a lot of things in terms of how we do building design and community design to build resilience into the system. And I think the Haiti earthquake was a reminder, also from a public health need, for public health to pay attention to community design and resilience and building community design. Same thing with the hospital system, okay, in terms of, you know, is there a single point of entry to your hospital that could fail in a disaster? I know early on in this, you know, you'd have to go over a bridge, over a stream that could flood. Well, if the stream flooded and you couldn't get to your hospital, you'd be in serious trouble. So resilience is something that you really need to build in here. And then with our first ever international response, I think it was also our first ever real deployment of the electronic health record of our national disaster medical system. And this was actually, I think, very exciting for us because we were able to get real-time information into our operations center from Haiti about what our teams were seeing and what they were doing. And so pretty immediately, one of the things that we saw was, gee, about 40% of the injuries we were seeing were children, were in children. And we didn't send anywhere near that kind of pediatric capability down to Haiti. This is where Mike and I sort of met one another and had a lot of conversations about what are we going to do about that. We were really able to turn on a dime because of the real-time nature of the information and find pediatric specialists and others to send to Haiti. And finally, I think Haiti really highlighted for us the need to plan for when the needs of a community in a disaster outstrip the available resources, sort of what we call crisis standards of care. Now, there are a lot of things that you can do before you get to those crisis standards. You don't wake up and fall off a log and say, whoa, I'm in crisis mode. But there are times when you're really in crisis mode. And Haiti, I think, really showed us that. In preparation for H1N1, it turned out that we'd done a lot of serious work. The Institute of Medicine had really helped us do some serious work to plan for it. We didn't have to use it in H1N1. We didn't run out of ventilators. The pandemic didn't end up being as serious as we thought it would be. But we did have to use a lot of those principles in Haiti. And so they've sort of had a little bit of a test drive now. I understand now that Ohio has its first draft of its crisis standards of care plan, and people are really to be congratulated for that. That is hard work. And I'll be really eager to hear about your experience now piloting it in different parts of the state. Probably the next public health emergency of significance that I was involved in dealing with was something that wasn't recognized at first as a public health emergency, and that was the Deepwater Horizon oil spill. It was, again, one of those unthinkable things, something we never planned for, the blowout preventer failing. Ironically, a couple weeks before that happened, we'd done a national exercise on what would happen if the blowout preventer on a nuclear power plant failed. The unthinkable, right? Fast forward to where we've been. But pretty shortly after Deepwater Horizon started, we started hearing about many, many kinds of health concerns from people who lived in the Gulf Coast. I would say there was an epidemic of fear. People smelled all kinds of funny things. They felt ill in ways that we couldn't really understand. And despite the fact that across the world we'd had something like 38 oil spills, I couldn't stand up in front of an audience and tell you that there's good science to tell you if oil and dispersants are bad for you or not. And that was not really a good position to be in. So I think that from that experience, we came to understand that with every one of these disasters, we have to have a science response capability. We have to have the ability to get scientific information about this disaster that we're not going to get otherwise, so we're never in the same situation twice. I'd say the same went for H1N1, the same went for Haiti, but I think it really hit home with Deepwater, and so we're really building that capability. Interestingly, the surveillance systems that we've built over the last decade and then really strengthened for use in H1N1 turned out to be the surveillance systems that we were able to use to figure out if bad things were happening to people because of the oil spill. We relied on poison control centers and syndromic surveillance in emergency departments all through the Gulf Coast to give us a handle on what was going on, and we weren't really seeing signals. But what we did have was a really significant behavioral health crisis. This struck an area that had been hit by Katrina, been hit by an economic turndown, been hit by Rita and Ike, and just as people were starting to feel hopeful again, the rug was pulled out from under them. And I think we came to understand in a very different way than we had before how critical behavioral health really is to resilience and to resilient people. And we also learned that we don't have really good science in this area. And so I would ask my colleagues at NIMH, so we know from the science of oil spills, what we did do was the Institute of Medicine convened a meeting for us in the Gulf, and we reviewed the experience with the 38 oil spills, and there was only one thing we knew really conclusively, that a large proportion of the population will develop serious depression, anxiety, and other mental health problems following oil spills. So my question was, what do we do to prevent it? That's a really basic public health question and a public health goal is prevention. We don't know. We didn't really have great ideas, and we don't have great science about how to prevent the sequelae of the disaster. We know that there's a predictable course. We know that many people will recover, that some people won't, but we don't know how to shift that curve to the left so that fewer people will get sick and that more people will recover. So that's, I think, a critical need we have. From that, we also recognize that in terms of our own national disaster planning, we have a national disaster medical system. We haven't had a whole system of how we do behavioral health response and a plan for incorporating behavioral health response into the rest of our health response. And I think it was a wake-up call for many that behavioral health is really central to health and well-being. So there's now an operational plan for behavioral health that was posted on our website a few weeks ago, and it's actually something that I'm really proud of the fact that we've been able to develop. Learning about the epidemic of fear from the Gulf oil spill, we had another epidemic of fear, I think, during the Japan nuclear crisis. Again, this whole thing is the unthinkable. Planning, do we plan for the unthinkable, or do we plan for all hazards, developing a set of capabilities that we need to handle anything, even the unthinkable, and having those basic building blocks of preparedness and response in place is critical for anything, including something like this. So this was another whole of government response, but it was parts of government that may or may not have been involved with some of the year's previous responses. So it was the Department of Energy and the Nuclear Regulatory Commission and the Environmental Protection Agency. And I know that when I showed up at the first meeting in this situation, and was, well, why is HHS here? Well, we learned, I think, very clearly from Deepwater, any environmental disaster, any emergency, people have health worries and concerns, and you need to get ahead of them really quickly. Aside from the fact that there was a tremendous fear about the health risks associated with radiation that might travel to the U.S., that might be in our food, that might be in our water, tremendous needs for guidance. And we had about 180,000 Americans living in Japan who also wanted guidance about what to do. So I think that gets back to that core capability that we've built in preparedness about communications. The need for communication with people here about what not to be afraid of, the fact that they could drink the milk, they could drink the water. You didn't need to be afraid that there was a run on potassium iodide, which is something that people take to block iodine uptake and radiation uptake in the thyroid gland. You couldn't buy any anywhere in the country because people were so fearful. They could harm themselves from taking it. So there was a lot of messaging, especially on the West Coast. Do not take the stuff. You don't need it. The sensor devices for radiation had become so ultra-sensitive that they would go off for a very, very small amount of radiation that wasn't harmful to human health. People would go through airports and they would set off the radiation detectors. You didn't even know there were radiation detectors in airports, did you? And, everybody would be really frightened. They would run away, they'd, want to decontaminate themselves, all these kinds of things. And there was a tremendous need for guidance, really, about what to do. And different people had very different perceptions of risk and the tolerance of risk that they were willing to take here. We also learned that different parts of the federal government themselves have different standards for how safe is safe in terms of radiation. And so we have a lot of work to do and have now been doing a lot of work across those different parts of government to harmonize our concepts of what is safe, whether it's about USDA and radiation in milk, or EPA and radiation in water, or the people who handle how much radiation can be in a cargo container, or the Postal Service. Everybody just had a different limit, and it made that response a little bit challenging. But again, I think in this whole of government mode, we were very able to cope with that and have made a lot of progress now on standardization. Probably closer to home was the Joplin Tornado. And I want to say a few words about that because we've talked about sort of a number of the public health preparedness concepts. This is a place where hospital preparedness really, really paid off. And I don't know how familiar you are with some of the issues there, but about 3 or 4 weeks before the tornado tore through Joplin, there had been a big national level exercise, and I think some of you probably participated in it. It was an earthquake planning exercise about the New Madrid fault. So the NDMS team in Missouri actually went and practiced setting up their mobile hospital. It took them 7 days to get the whole thing up. Okay? About 3 weeks before the tornado hit, St. John's Hospital went live with Epic as its electronic health record. Okay? Tornado goes through, destroys the hospital. They successfully evacuated 183 out of 187 patients in a very short time, got them all to safety into another hospital. And I can't tell you how many people have come up to me and said, we really hate that you made us do these drills and exercise. We don't like them, but you did make us carry people down the stairs on boards, and you did make us do this, and we would not have been able to do it otherwise. Epic, the electronic health record folks, by protocol began printing within about 20 minutes their electronic health records so that when patients got transferred to another hospital, they could go with their electronic health records. And those that could receive electronic health records just were able to receive them. The NDMS stood up the mobile hospital in 3 days instead of 7. And it was an amazing sight to see that aluminum pole going up the middle with Ethernet cables duct taped around, connected to laptop computers, connected to their electronic health record, seamlessly able to take care of their patients in their mobile facility as they are now. Quite a testament to electronic health records. The substance abuse clinic was destroyed. It had about 60 or 65 people on methadone. The next day, they were all able to get their methadone in Springfield, Missouri, because the substance abuse clinic had electronic health records, and they could just transfer the information to Springfield. We had a pretty significant mortuary operation there because the local coroner was pretty overwhelmed by the number of fatalities. Many of the dental practices were now electronic, and we're able to use the electronic dental records to do victim identification really for the first time. And finally, in terms of the whole healthcare system resilience factor, the physician's office and dental offices that were electronic have found that they've been able to get up and reconstitute much faster, get back in business in the community much faster than those who were destroyed and lost their records. I think many of you know that the CEO at St. John's has been really visionary, and the day after the tornado came in and said, you know, anybody who works in this hospital is guaranteed a job for a year. You might be doing a different job than you were, but we will employ you and guarantee a salary. Any physician who works in this community who continues to admit patients to this hospital, we will guarantee your salary for a year while we get back up and on our feet. And I think his leadership and decision-making had a huge amount to do with the resilience of the healthcare system. And finally, there was a huge amount of attention paid from the get-go to behavioral health as part of resilience, and particularly to children's behavioral health. Because remember, kids came out of their basements or out of their bathtubs and got the mattresses off them and looked up and saw bodies in the trees. And it was a pretty traumatizing event. There's been a huge amount of energy and effort on behavioral health and resilience. And finally, as they've stood up their temporary communities, they've done this now with some attention to some of the social determinants of health, places to exercise, the layout of the structures, et cetera, so that we can think about ways to keep people healthy during those events. So just a couple of overarching lessons here, and then I'll stop and take questions. First of all, I hope that you've been able to see through this that a number of the investments that we've made in the public health infrastructure and the healthcare system infrastructure have really, really paid off here. that a whole of government response is absolutely critical, working together across agencies and across all the different levels of government. That effective leadership and decision-making is always key. You can never underestimate the needs for communication and people's fears. So I think we've made a huge amount of progress now in a lot of key areas. Since H1N1, we've done a whole review of our medical countermeasure enterprise and changed the business model. We can talk about how we've modernized it. We've focused on this whole of community preparedness and especially on the needs of children. We've got a behavioral health response plan in place. We're doing a lot to strengthen healthcare system preparedness. We talked about that this morning with coalitions, with strengthening day-to-day care, with electronic health records, with working to strengthen emergency medical systems. We're working together with some of you in this room on a concept that we call budget preparedness. Because it took, in fact, about 6 months from when Congress approved money for H1N1 to when it got out the door from local health departments to people who they needed to hire, that's not a way to manage an emergency. And so we've been looking across government, and again with state and local governments, about how to move money quickly. And something I didn't mention, but I do want to just talk briefly about, our ability to help the people of Japan, our ability to respond in H1N1 around the world really highlights the importance of health diplomacy, and that we have to always remember how globalized our world is, and at all different levels, health diplomacy is pretty critical. Unfortunately, the threats to our national health security persist. I'd like to name just a couple threats. Number one, terrorists. Number two, Mother Nature, who's a pretty effective terrorist in and of herself. Number three, man-made disasters, as we've seen this year. Number four, in my mind, the current federal, state, and local fiscal crisis, particularly as it's resulted in the loss of about 40,000 state and local public health jobs around the country over the last year and a half. And number five, and perhaps the most important, is the failure of imagination. But even if our imagination fails, I think if we have in place the building blocks of preparedness and response, those capabilities that we're asking you all to work on, that we'll be able to handle just about anything. So thanks. It's been a pleasure to be here and love to take questions. Okay.
Today at the City Club, we are listening to a special program featuring Dr. Nicole Lurie, Assistant Secretary for Preparedness and Response at the Department of Health and Human Services. We encourage you to formulate your questions for our speaker now. Remind you your questions should be brief and to the point. We welcome all of you here, especially those who are guests. We hope you'll join the City Club and become active in the ongoing civic dialogue. Tomorrow, Wednesday, January 25th, the City Club will host a panel discussion on the body in pain, including a panel of local experts discussing the causes and treatment of pain. Also on Friday, January 27th, the City Club welcomes Karen Mills, who's the Administrator of Small Business Administration. If you wish to make reservations or order a CD or DVD of today's presentation, please call 1-888-223-6786 or locally 216-621-0082. We are pleased to welcome guests at tables hosted by the Center for Health Affairs, University Hospitals, Metro Health Medical Center, and the University Hospitals EMS Institute. We thank you for your support. Now I'd like to return to our speaker for the traditional City Club question and answer period. We welcome questions from everyone, including guests. Holding the microphone today is City Program Club Director Carrie Miller. Now our first question.
Dr. Lurie, my question is concerning pediatric children.
Mm-hmm.
What are the lessons learned, and what are your recommendations to us for reunification of children in disasters?
What a great question. Obviously, reunification of children, keeping the family unit together is something that is really essential. You know, our major lessons learned, I think, there have been from Hurricane Katrina, from Rita and Ike, and then from the experience in Haiti. All of those experiences have really forced us, number one, or pushed us to develop patient tracking systems. I think there are a lot of lessons learned now in terms of new technologies to help with reunification and to have centralized places to do it. I'm really impressed very much with the role that some of the new social media technologies, text messaging, reverse lookup, directories, and others can play in the reunification process. I also want to stress that it's really important, and I think we really saw this in Haiti, how critical it is to be really sure of who you're reunifying with whom, when it is that you assume that a child is missing or not, or a parent is missing or not. I think we saw a lot of really well-intentioned evacuations and separations often of people from kids who then turned out to be very difficult to reunify. But at the end of the day, the resilience of a community is very much determined by how its children and its families fare. And reunification is clearly one of those things. Those hours when people have no idea what's happened to a loved one, whether it's about reunification of children and parents or any other missing people, are some of the most challenging times. And the act of reunification, as well as the act of providing information to people about what to expect, when to expect it, and continuing that communication and dialogue until the reunification or identification is complete, is something that really can't be underestimated.
First, Dr. Lurie, I would thank you for coming back to Cleveland, and thank you for your leadership at the national level. I wanted to veer, Mike said, to be to the point, but quickly I'd like to say that in this community and in this region, in this state, I know that all the people here, when you speak about public health, hospital systems, EMS, EMA, that we're very proud of how we've done across this state. Ratings, if you look at Trust for America's Health, I think we do very well, and the commitment to preparedness is exemplary. Steve is here, and I'm glad Steve Wagner's here from the Ohio Department of Health. He's been a great leader at the state level in that regard. One of the things that worries us is, sometimes it feels like to us that, they don't need us until they need us, right? So we're out there, but oftentimes I don't know that we, in the budget crisis that you described, have done a good enough job of educating legislators about what we do and about the importance of this capacity, this infrastructure that we built, and how quickly it could disappear. Your feelings about that aspect of what we can do, perhaps, to make the good work that we've done known and understood, perhaps, in competing budget priorities would be helpful to us. Thank you.
Great. Well, let me try to make 3 key points in this area. First, I very firmly believe that good preparedness is built on the back of strong day-to-day systems and care. So if your systems are rickety day-to-day, you're not going to be prepared. If you can't do surveillance day-to-day or epidemiology day-to-day or surge in your emergency department or your hospital day-to-day, you're going to have a really rough time in an emergency. That means that the investments that we make in preparedness have a payoff in day-to-day care. And I think that that's something that's not so well understood by the people who make our budgets. And I think it's something that's important for us to communicate to them, both by example and through measurement and reporting. They like to see those measures getting better. I don't want to see us decline in our preparedness, but I think we need to be prepared to speak some about what the consequences would likely be if our preparedness degraded. So I think that would be the first point. Second, I would want to say, invite them over. Have them see what you do. Show them by example. Even some of the smaller disasters or smaller public health crises that you deal with, you could not have done as well as you could now that you've built this system up. And so helping them understand that, I think, is really terribly important. And thirdly, I would say, show them how you're being more efficient. Because I think that the budget challenge is challenging us in a lot of different ways, but almost every health department that I've spoken to has taken it as really a clarion call to think about whether there are efficiencies to be gained, and has done some really innovative things, and help them understand that you at your end have done your part to really be fiscally responsible. You've leveraged partnerships in different ways. You started out your comments by talking about the healthcare, EMA, public health collaboration. It didn't used to be like this, and everybody is stronger for it.
You talked a lot about building capacity in hospitals. in response or to prepare for emergencies. And I had an opportunity to spend a couple years in Louisiana after the storms, and not in a healthcare capacity, but and I would also like to say that I appreciate and commend adding such a strong level of behavioral health to the action plan, because as many desks as we are putting in schools, they were only there for students to hide under when it rained. So that's a great thing. But I would like to ask about the volunteer role and the plans that you've developed and that you're spreading across the country, because oftentimes we found that we were more in the way than we were helpful. And so I guess there's a communication piece there that I'd like you to comment on, and what the role is that volunteers really can play in these situations.
Great. Thanks for the question. First, let me make a comment about the hospital preparedness piece. The hospital preparedness program has that name, but we're really talking about healthcare system preparedness. And we're really talking about a whole range of healthcare entities across the community. You know, whether they are nursing homes or dialysis centers or surgery centers or hospitals or primary care offices. I wanted to just be sure that that point is clear, or behavioral health services. So from the volunteer perspective, I'd make a couple of comments. First of all, in the capabilities that we believe that both the healthcare system and public health need to have is that capability for volunteer management. Because, in fact, most major disasters are accompanied by this incredible influx of volunteers, and managing them so that they can be helpful and not get in the way can sometimes be a job in and of itself. And there are good practices out there for how to do that. The second thing I would say is that there are a lot of ways for people to volunteer or prepare to volunteer. And I would encourage people who want to volunteer, certainly on the medical side, to think about joining your local Medical Reserve Corps. Is there anybody here from the Medical Reserve Corps? Or who's a member? All right. Good to see. To think about joining a Medical Reserve Corps. If you have certain specialty skills, particularly pediatric specialty skills, think about joining one of the enhancement teams that we have, so that in the kinds of disasters we're talking about, that you're sort of pre-registered and pre-credentialed to go. Think about joining an NDMS team. But think about these things in advance and prepare yourself both physically and psychologically to be able to volunteer and to be helpful. If you don't want to work with a government entity, I would say don't go necessarily on your own, but work with an established group that is able to effectively deploy volunteers. And last, I would just point out that there are loads of opportunities to volunteer day to day in your own communities in places of need.
Dr. Lurie, as a non-healthcare professional, you talk primarily about disasters or critical incidents that are geographically based in one location, such as Joplin or the situation in Japan or Haiti. It appears to me that one example of a more broad-spread disaster was the series of tornadoes that went across the southeast a couple weeks before Joplin, I believe.
Yep.
And they were much more dispersed and also probably much more rural. Does that present a different set of challenges from the point of view of response and care and how the systems work together that you could address?
It does, and I'll point to Hurricane Irene sort of coming up the coast as another one of those things, A, not knowing where it was going to hit, and then B, having it soak a large area of the country. I think the issues for rural areas for almost all aspects of life, including disaster preparedness, are a little bit different because things are more geographically dispersed. It takes longer to get to resources. The infrastructure, even in terms of the communication infrastructure, sometimes the road infrastructure, all of those things are just at often a different level of development than they are in more urbanized areas. And of course, all of those pose challenges. At the same time, some of those areas also have populations that are much more used to handling things on their own, and sometimes a little bit more able to sort of get out and do that initial first 24 hours to help is there. sort of stuff on their own. I actually visited Alabama just after that whole string of tornadoes hit. And what I would say is, although there were some very unique challenges and a huge amount of area where roads needed to be cleared and communication infrastructure needed to be reestablished, the basics were the basics in terms of organized response, in terms of needing to use an incident command system, in terms of reestablishing communication, in terms of the priority order of what it is that you do, and in terms of the capabilities for public health and healthcare systems to serve their population. My belief is if you have those capabilities down, then any unique situation you'll be able to flex and adapt to. But otherwise, I think a lot of it has to do with just the fact that the infrastructure is different. The rural areas have much smaller healthcare facilities, often critical access hospitals. They can get waivers to expand, but critically ill people obviously need to be transported to a place that they can get definitive care. So we did find that in the tornadoes in the southeast, actually the Alabama DMAT system, for example, was pretty robust. They felt that they could handle it themselves and handle it with mutual aid agreements with neighboring states, and I think that they did that quite well. When it came to recovery functions, that was an area where we've played and continue to play a more active role. And you're right, it's over a huge geographic area, and 2 of those counties got hit yesterday by smaller tornadoes. And although the damage was less, it is a re-traumatization that people go through that's pretty upsetting as well. Again, highlighting that behavioral health centrality.
Further on the behavioral health, Dr. Lurie, you spoke about the fact that some incidents like Japan and the Gulf water disaster create angst or anxiety in people. It seems that the greatest terrorist threats are things like something that might attack a water system or a dirty bomb. How do you educate the public to be better informed and know what to do without exacerbating the concern and anxiety that might create?
Well, I think public education is always a good thing, and public education, particularly about concrete things to do, to either plan, what to do to make a plan, how to prepare yourself, and what to do to take care of yourself if something happens are some of the most important things you can do. People are less anxious if you give them something concrete to do. And I think that's been shown in disaster after disaster after disaster. So the work that we do in asking people to make a plan, some people think this sounds really hokey, but it's really important to make at least a rudimentary plan, discuss it with your friends and family, have a meetup place, do those kinds of things. And I think the data show that that doesn't really provoke anxiety. It just has people thinking about it and has people differently prepared. We're about to launch, I'm about to announce the winner of our first national competition in building resilience through Facebook, where we've asked people to identify a couple of their Facebook friends to be lifelines for them in the case of a disaster. That means that you have to make a commitment to a friend, at least online, and hopefully, share a plan and offer a place to stay or tangible help in a disaster. Building those bonds between people is something that reduces anxiety, not enhances it. Yes, if there's a terrorist event or a contamination of water supply, people are going to be fearful. They're going to be fearful in any event. But getting out there early with communication about what's going on that's reliable, how they can protect themselves, and giving people something tangible to do are the most important things I think that you can do acutely.
Hello. Hi. Thank you for taking my question, Dr. Lurie. As an EMS agency, and we've been involved since Katrina in the field at all the events, where we find ourselves straddling back home between being public safety and public health, and we've been part of the national debate as to where EMS should be positioned currently under NHTSA. Wondering what your thoughts are, if there is a better way to coordinate EMS in the nation and be a part of a different structure in the federal government.
I will say it has been a national debate. I'm happy that it's been a national debate because I think the issue about needing a lead federal agency for EMS is finally getting the attention that it needs and deserves. As you say, fundamentally, there are components of both. Half the states in the country, EMS is part of a health department and is regulated by public health. The other half, it's by public safety. I don't know that in that sense there is a one-size-fits-all solution. But the federal agencies that are most closely aligned with EMS clearly need to, in any configuration of a lead agency, do a better job working together. We, through my office, recently sponsored a meeting of all of the national EMS agencies. I can't, there were like 17 or 23 of them. A huge number of organizations, all of which represent a piece of EMS. And yet, when all was said and done and they all came to the table, many of the priorities of all of those groups were the same. So I think it really is going to take, and I think I speak for my colleagues across the agencies that deal with EMS are really looking forward to providing more federal leadership in this area, and I think that it has our full attention, and we're very engaged in it right now.
Today at the City Club, we've been listening to a special program featuring Dr. Nicole Lurie, the Assistant Secretary for Preparedness and Response in the Department of Health and Human Service. Thank you for your kind attention, and we now stand adjourned.